Are you missing out on hormone replacement therapy because you are getting some misinformation? Let's chat about what the research says and doesn't say about hormone therapy and whether it might be a good option for you that you are maybe just passing by or thinking that it is unsafe or not the right option for your needs. Let's just talk about menopause hormone therapy in general. We know that when we look at research, it is the most effective treatment for vasomotor symptoms, hot flashes, night sweats. We also know that it helps with sleep disturbance, vaginal dryness, and hormone replacement therapy usage in the early 2000s dropped a ton. And this was actually due to fears that had to do with a Women's Health Initiative study. So this study basically looked at hormone replacement therapy in a population of women and largely came to a number of conclusions that hormone replacement therapy was not safe. There were a number of reasons for that. First of all, the study was done in older women. Second of all, the study used oral estrogen, which we now know oral estrogen is not the safest way to deploy estrogen. In fact, we actually see the same benefits from giving transdermal or topical patch or gel estrogen. We see the same benefits without a lot of those risk factors. And let's talk about some statistics I have here. We know that roughly 30 to 40% of women in their 50s were on hormone replacement therapy in the year 2000. By 2010, this fell to about 7%. This is in the US. Now, in the US today, or as of a few years ago, fewer than 5% of women aged 45 to 59 were using hormone therapy, and a Canadian analysis similarly found only 9.5% of women were current hormone replacement therapy users, with 22% past users, meaning women decided to stop taking hormone replacement therapy. This was, in the mid 2010s. The dramatic decline means that a lot of women are actually moving through life without their symptoms being properly managed or adequately treated. And this could be number up to 85%. I see this in my practice all the time, is that a lot of my patients' physicians are also not comfortable with giving hormone replacement therapy. Maybe they just are not taking additional education in this topic, or they still feel like the research of the past is how they're guiding their current treatment options. And this is leading to a lot of patients not getting adequate treatment, in my opinion, or getting treatment in time. When we look at hormone replacement therapy, we know that there is a window of opportunity. There is a time frame with which, if we treat, we see the maximum benefit. And if we treat after that window of opportunity, we don't see as much benefit, and there can be some risk. That window of opportunity is within the first 10 years of going through menopause or before the age of 60. And we know that this is due to lingering blanket fears that hormones are dangerous. Many women and clinicians are weary about some of the risks. We see breast cancer or blood clots, and they avoid it. And we know that this is due to lingering blanket fears that hormones are dangerous. Many women and clinicians are weary about some of the risks. We see breast cancer or blood clots, and they avoid it even when patients would likely benefit from it. So as a result, women are navigating these midlife issues, hot flashes, night sweats, vaginal symptoms that are not being managed. And sometimes what's happening is we're having what we see as a polypharmacy approach with still notable side effects when the patient would probably benefit from hormone replacement therapy. One of the most common examples here is an antidepressant as a substitute for hormone replacement therapy. We actually know that one of the most common HRT substitutes is typically an SSRI or an SNRI. And here's some of the statistics. Nearly 1 in 4 women aged 40 to 59 is on an antidepressant. Again, some of these prescriptions are men because these women are suffering from clinical depression, but we know that perimenopausal women are often misdiagnosed with primary depression or anxiety disorders when their symptoms are hormonally driven. We know that perimenopause, which is the 7 to 10 years, that transition period leading up to that final menstrual period, also known as menopause, is the most symptomatic years, and women are much more likely to be diagnosed with anxiety or depression during this time. This is problematic because the SSRIs or the SNRIs might improve your mood, but they do not treat the underlying estrogen deficiency. And so what we find and what I see with my patients is they're given an anti-anxiety medication or antidepressant and they just don't have relief. They're like, I still don't feel like my symptoms have been managed despite going on this anti-anxiety medication. And some of them actually have side effects from these medications, which are more pronounced in the perimenopausal and menopausal stage of life, mostly because some of these side effects are low sex drive, and they already had a low sex drive, right? Some of them feel foggy when they've also been experiencing brain fog as a symptom of perimenopause. We know that depressive symptoms can happen in the perimenopausal transition in up to 40% of women. And so we need to make sure that we are actually treating the root cause. When we look at some of the studies, we have actually seen a pattern of inappropriate antidepressant prescribing for women in perimenopause. In one clinic audit, many women referred for menopause symptoms had already been started on antidepressants long before anyone considered hormone replacement therapy. Often HRT is introduced late or not considered at all, highlighting this as a missed opportunity for both patients and clinicians to have a lot more targeted relief. Now, we know that certain SSRIs and SNRIs can modestly reduce hot flashes. We know, for example, paroxetine is approved for hot flashes in the US, and this is wonderful news for women who cannot have hormone replacement therapy, who just cannot have estrogen for whatever reason, right? This is not what we're talking about. We do know that hormone replacement therapy is the most effective for classic menopause symptoms, and this is per the North American Menopause Society, which emphasizes that estrogen remains the most effective treatment for bothersome menopausal symptoms. We know that antidepressants tend to reduce hot flash frequency by a smaller degree, but they don't improve any other estrogen-sensitive issues like vaginal atrophy, which is something that people don't talk about. Antidepressants don't touch bone loss, which is something that hormone replacement therapy can benefit. We also know that, again, SSRIs can cause drawbacks, mainly sexual dysfunction. So we have low libido, anorgasmia, weight gain, insomnia, fatigue, and emotional blunting. This is what I was describing, issues we already have as some menopause-related complaints. And we know that research has linked long-term SSRI use in older adults to increased risk of falls, fractures, strokes, seizures, and dementia, and even diabetes. And so, actually, there's no dementia, just diabetes. These are particularly pronounced when antidepressants are used inappropriately. So in women without major depression, given an SSRI because they're suffering from hormone-related mood issues, this can be a problem. Now, when we restore estrogen levels, this can improve mood, improve sleep, and we know that improving sleep alone has documented benefits for mood. We also know that the lack of sleep that happens in perimenopause and menopause is actually partly to blame for some of the mood-related symptoms that are experienced. When we restore estrogen levels, this has benefits for cognitive function, bone density, cardiovascular health in appropriate patients. And so we know that when we give it appropriately and early enough, this can be a net positive and have benefits that SSRIs or antidepressants don't have. Now, when we look at things like bladder issues, we know that menopause doesn't just cause, hot flashes, night sweats. It also can cause overactive bladder symptoms. A lot of women in perimenopause are diagnosed with an overactive bladder. We can have symptoms of urinary incontinence, which are part of the genitourinary syndrome of menopause. This can manifest as urgency, frequency, bladder incontinence, and this can be due to also urinary tract infections that are recurrent because of the lack of estrogen that happens at this time of life. Many women are prescribed for medications for an overactive bladder, such as anticholinergic drugs. There are a few, but these treat the bladder muscle overactivity, and they don't address the tissue changes that happen from a lack of estrogen, right? So we know that bringing estrogen locally to the vaginal tissues can help regain moisture, regain the good bacteria that's going to help prevent yeast infections and chronic urinary tract infections that a lot of women experience during this time, instead of going on multiple rounds of antibiotics to treat consistent urinary tract infections. We know that vaginal estrogen has been shown to improve bladder storage capacity, reduce urgency, and help restore the normal vaginal flora. And by treating the estrogen deficiency locally, this can target a lot of the urinary symptoms that we're experiencing here. The other thing to note is that a lot of these bladder medications, one of the problems is that there are adverse effects associated with them. So many patients stop therapy because of dry mouth, fatigue, constipation, and so they don't come without risk. So we have to decide when we're treating patients, what is the best next step for this patient that has a net positive and reduces the risk as much as possible. On the other hand, we know that vaginal estrogen is generally very well tolerated with minimal systemic absorption, and it can reverse vaginal and urethral atrophy, which improves pelvic health. Now, studies show that local estrogen significantly improves overactive bladder and urinary incontinence symptoms in postmenopausal women. Now, the combination of vaginal estrogen and overactive bladder medication can be used to maximize the benefits while using a lower dose of the drug. So I'm not saying don't use these drugs at all, but being mindful of the best approach for the individual at hand is really, really important. Thing to look at is heart health. We often see women in perimenopause and menopause have their cholesterol levels go up. And a lot of doctors will jump to putting them on statin therapy. Now, I'm not saying it's not indicated, and in some patients, it actually is. However, what we know about hormone replacement therapy is the timing hypothesis is really important here. When we get patients on hormone replacement therapy at the right time in their life, so within 10 years of starting menopause, or before the age of 60, we know we can actually have a net positive and sometimes just a neutral impact on cardiovascular disease. This is due to a number of reasons. We know that estrogen, specifically hormone replacement therapy with estrogen, can actually raise HDL or that healthy cholesterol, which helps counteract some of those risks. It also can help to mitigate insulin resistance. And insulin resistance is a huge driver of cardiovascular disease. And so when we do that, we know we can have a positive effect or neutral effect on heart health versus letting someone go into menopause without any hormone replacement therapy can just inherently reduce their risk of cardiovascular disease. Bone health is another area that I feel like isn't talked about enough. When we looked at research, hormone therapy significantly reduces bone loss and fracture risk. Studies have shown that there was a 33% fewer osteoporotic fractures in women on HRT versus placebo. In women who do not receive hormone replacement therapy, often physicians are prescribing bisphonates or other osteoporosis drugs that help strengthen bone, but they do come with their own limitations, side effects, and risks. We can use HRT as a layer on top of everything else that we're doing with diet and lifestyle and strength training. We know that doing strength training is really important for bone health. We also have calcium and vitamin D. And so HRT is not the only tool, but it is a tool that we can use, and we shouldn't be ignoring if a patient is a really good fit for starting it. And what I see a lot is sleep. Sleep issues cause brain fog and mood issues and cravings. And then that sleep issue leads to someone eating more than they had intended because you're more likely to make different choices when you are lacking sleep. You're more likely to have poor mood. You're more likely to lack focus. You're not going to have the energy to exercise. So if we have poor sleep, everything else falls downhill. And when we can address that sleep, everything changes. And I see patients who come to see me, they have hot flashes, right? We have to ask ourselves, what's the reason why you're not sleeping, right? Maybe they have hot flashes, maybe they have night sweats. And so looking at the reason why they're not sleeping first, if it's hot flashes, hormone replacement therapy might be the number one thing to support them. Now, we do know that hormone replacement therapy on its own has benefits for sleep, progesterone, and estrogen. And so looking at that as part of the picture is really important. And this can help us avoid potentially a prescription for sleep medication, which creates a prescription for mood medication, which makes us make more poor choices, and we're less likely to move and exercise and make good health choices. And now we're on a statin, right? You can see how this quickly turns into polypharmacy. And it's not that we need to avoid medications, but we need to use them when they are necessary and needed and serving us the most benefit for what we are trying to achieve. Now, having said that, hormone replacement therapy is not for everyone. Obviously, it does come with some risk. Nothing is risk-free. We know that it is contraindicated in someone specifically who has an estrogen-sensitive breast cancer or in someone who has a history of blood clots and stroke. We need to be evaluating that individual risk. Doesn't mean that they cannot have it, but we need to be having that individual risk assessed. Now, we do know that combined estrogen and progestin therapy does carry a slight increased risk of breast cancer, but that is after 5 or more years of use. And if we look at this, in compared to some lifestyle interventions or lifestyle choices rather. This is excess risk is comparable to having 1 to 2 alcoholic drinks a day, and this is mainly relevant with prolonged use. We also know that HRT, specifically oral estrogen, does come with an increased risk of blood clots and stroke. Though the absolute risk in women under 60 is quite low, we see this risk as less than 1 extra stroke per 1,000 women per year of estrogen progestin therapy, and no significant excess risk observed for estrogen alone in younger postmenopausal women. Again, when we're choosing the dosage and the route of administration, typically we're going with transdermal estrogen, which does not necessarily carry that same risk. This is mainly with oral estrogen. We do know that there is a small risk of venous thromboembolism with oral estrogen, oral HRT. And so this is typically the risk is in obese patients and older patients. Again, these are some of the risks, but we have to make sure that we are making a informed choice that is not based on fear and outdated research, but a choice that considers the entire patient, your goals, and the whole picture. And in my world, we certainly don't just do hormone replacement therapy. We're doing a lot of other things. We're looking at your diet, we're looking at your lifestyle, we're looking at other components of your health that require replacing nutrient deficiencies, treating gut health. And so this isn't the only tool we use, but I think it's important that we don't disregard this as a tool when it can be really beneficial because of fear and misinformation. If you have questions, comment below, and don't forget to subscribe so that you get notified for every video I post. See you next time.